Hello, I'm Dr. Amresh Srivastava, and I'm a full-time academic faculty at Department of Psychiatry, University of Western Ontario. Myself and Dr. Charles Nelson, adjunct professor of psychology in the same university, have together developed this course, which is titled as Coping Up with Clinical Challenges of Risk Assessment towards a New Comprehensive Instrument. This course deals with intervention and prevention of suicide, which is an important area of psychiatric public health. The course is divided into three different parts. The first one deals with significance of suicide and suicide risk. The second part deals with challenges of practice in the field of suicidology. And the third one deals with reviewing the concept of risk and explaining how we can adequately measure it. The objective of this course is that we should be able to understand scope and limitations of contemporary risk assessment practices and also address the issue how to maximize the assessment practice in clinical psychiatry. Suicide is a public health problem. It happens everywhere. There are no boundaries of caste, creed, culture, or region. It's a global public health problem which affects about 1 million people who die every year. It is 10th commonest cause of death and ranks second or third most common cause of death in young people between the age of 15 to 25 years. It happens across the boundaries. The World Health Organization statistics report that incidence of suicide is very high, that is more than 13 per 100,000 in Far East countries, former USSR, Australia, Sri Lanka, and some of the European countries. It's in the medium range, that is 6 to 12 per 100,000 in North America and Canada, while it is reportedly low in South American countries. There are several reasons and various causes why the rate varies, and we'll talk about some of these. We need to remember that suicide statistics are grossly underreported from most countries, primarily because of stigma attached to suicide. Suicide is Canada's silent tragedy. Suicide rate in last 40 years has gone up 3 times, and we have a male to female ratio of 3:1. Currently, about 8 to 10 per 100,000 rate of suicide is seen in Canadian population. In clinical work, while dealing with a person who is suicidal, the most significant skill is to be able to assess risk with high quality of precision and to be able to undertake measures that are appropriate to minimize the risk. We have to also pay attention to newer high risk groups being seen in Canada and other countries, and one of them is, of course, the military services, current teenage population, and some of the medical professionals as well are seen as people at high risk for suicide for various reasons. As I was discussing, the clinical work, while dealing with a person who is suicidal, the most significant skill is to able to assess the risk with high quality of precision. There are several inherent limitations in performing the task of accurate assessment, and we will discuss this aspect. One of the main preventive strategy adopted by experts, particularly from World Health Organization, is the treatment of mental disorder. This argument is based upon number of studies that have reported that 90% suicides arise from mental illness. An absence of a mental disorder is documented in less than 10% people who kill themselves, and about 20 to 40% among people who report attempted suicide. Generally, there are two groups of individuals who attempt suicide: those who have a psychiatric disorder and face a psychological and social distress, and those who do not have a psychiatric disorder and only face psychological stress. The task of accurate prediction of suicide is complex, and one of the many reasons is very low epidemiological prevalence in general population. It is estimated that 10% of general population seriously considers suicide at some times in their life. However, those who persist with the suicidal ideation are very low numbers. Suicide happens in people who contacted the services for treatment and help, and suicide also happens in people who have never contacted the services and are outside the healthcare system. And therefore, recognition of the risk as clinical pathological parameter is the main challenge. It is therefore necessary that prevention must target two different populations. One is the general population, which is outside the system of healthcare, and second, the population which is within the healthcare system. It is not uncommon in clinical practice to see that the patients who are being treated have unfortunately committed suicide. 1 in 6 completed suicides are reported to be in patients in psychotherapy, and about 50% of completed suicide have had previous experience in psychotherapy. 1 of every 2 psychiatrists is likely to lose a patient to suicide across a mean year of 20 years practice. Similarly, 17% of psychology interns across 5.2 years of practice are likely to lose a patient to suicide. And therefore, the main question which arises: why do people behave differently in similar stressful situation? To recap, what is the purpose of risk assessment in clinical practice? The first is to establish clinical needs. One needs to identify what are the needs of a patient, what kind of treatment plan needs to be developed. And that's the clinical piece where assessment is required. It is also necessary that clinicians are able to predict possibility of a suicide with great amount of precision. So that is the second indication why an assessment is necessary and documented. The third is to decide the level and quality of care which is going to be continued, or there are special situations in which this needs to be decided. Then there are issues about management, there are issues about policy matters of institutions and countries, and most importantly, there are issues about patients' safety. These are some of the situations where a strategic, comprehensive, and sensitive risk assessment is necessary. It goes on to define the standard and quality of care that we all provide to our clients. To address the issue of suicide prevention, we need to identify the gaps in the services. Normally, when a patient arrives, an accurate diagnosis is fixed, assessment is done, treatment is planned, and effective care plan is developed for risk management. In the third step, the current knowledge of risk is enhanced. There is need for continuing education to medical health professionals and mental health professionals, and there is need for knowledge translation and effective prevention. The gaps can occur at any level. It can be at the level of diagnosis, it can be at the level of care planning, or it can be at the level of implementation of the plan. Let's see a case report and think about what could be the level of risk which each one of us will determine. A 29-year-old female who has been in a relationship, is quite educated and settled in her career. She attempts overdose with a combination of medications and goes into respiratory failure. Survived after spending 2 days in intensive care and was referred to psychiatric hospital on an involuntary admission for assessment on Form 1. There is no history of any previous attempt, but there is history of depression since the age of 16. She has been treated with several SSRIs with good response and medications were stopped. She has a family history of depression and a history of suicide attempt in first degree relative. There is no issue of substance use disorder. There is no history of alcohol or drugs. The psychosocial situation prevailed was that her boyfriend broke the engagement, which led to stressful situation and there was an attempt of overdose. Her current mental state was unremarkable. She denied any suicidal thought, ideas, or plans. The question is, should she be hospitalized or not? And should she be voluntary or involuntary if admitted? The risk in present case is that there is a current loss of and stressful factor. There is history of depression in herself and there is history of depression in her family. There is history of suicide in the family and there is history of suicide recently in herself 3 days back. We will recap this situation when we are talking about the new assessment tool. Risk assessment is an important clinical responsibility which is life saving. Literature on risk factors has become voluminous. However, a traditional risk assessment does not take into account the most relevant factors. Psychopathology is currently understood in biopsychosocial terms, and the same applies to risk of suicide. Let's recap the situations of assessment and monitoring an outcome in a given clinical context. There are three different possibilities that in clinical practice, me and you do high quality risk assessment and we develop a very high quality management and monitoring plan, and still the client lands up or commits suicide. The second situation is where a high quality assessment has been done, but there are resource constraints and the management is inadequate, and there is an incident of suicide. The third situation is where a poor quality risk assessment has been done and intervention monitoring also was inadequate and there is an incident. In all the three situations, what is crucial is how well the assessment of suicidality has been done. Thus, we observe that resource, manpower, and logistical supports are insufficient to prevent incidents. The prime requisite is a qualitative and accurate risk assessment. Some situations are vulnerable by their own nature of complexity. For example, suicide is high in recently discharged patients. Thus, these patients require very close monitoring. Studies suggest that the standard mortality rate of suicide is 4 times higher than general population in first 28 days of discharge from hospital. Few other studies have reported a still very high standard mortality ratio of about 48.9. Risk assessment area has certain inherent limitations. The first one is that there are far too many factors and too many variations in this subject. Research has highlighted that perhaps a new definition of suicide needs to be found because of the heterogeneity and variations that is seen in the subgroups. Several psychological and biological markers have been proposed neither are free from false positive and false negative results. Conventional method of assessment is a thorough clinical assessment enriched with aid of standard interviews. The rating scales are useful whether they are self administered or clinicians administered. Most clinicians combine clinical experience with evidence based research to judge the suicidality in a given context. An standard suicide rate assessment often relies on clinical experience alone. There is no single source or authority which defines the standard of care in suicide risk assessment. We now come to the second module, that is challenges in practice of suicidology. If you look at the problems arising from inadequate risk assessment, they are of two different nature. One in the field of legal psychiatry, and the second is in the field of clinical psychiatry. There are three different partners in the whole system, or three different stakeholders, let's say. One is the organization where the suicide happens, which undergoes loss of reputation, malpractice litigation, and lower acquisition of lower standard of care. And the second, the patient's family, where the incident has taken place. There are issues about disability, repeated suicide, and consequences of burden on key relatives and other family members. And of course, the physician. The clinical frustration, litigation, and administrative problem that a physician goes through in dealing with the consequences of a suicide within the care system are painful and very disturbing. When we think about coping up with this situation, the guiding principle stands out, balancing the care between dignity and liberty. And the principle which has been frequently talked about is liberty should not be compromised any more than is essential, even when suicide is a possibility. It's a forensic area, there are legal consequences, and number of cases have been in the courts. Normally, the courts determine the merit of the case based on three different criteria. And what they ask, number one, is has there been failure to determine the imminence of the suicide behavior? The second aspect which courts question is if a high risk suicide factor were identified and whether appropriate steps were taken. And the third criteria which they use is the thoroughness of treatment plan and its implementation. Therefore, it places a huge responsibility of doing what we are supposed to be doing, documenting what we are supposed to be documenting. The American Psychiatric Association's guideline on assessment of suicide behavior is an excellent piece of material. It defines the assessment process in 5 different steps. The first one is need to conduct a thorough psychiatric evaluation, specifically inquiring about suicidal thoughts, plans, and behavior, to establish a multi-axial diagnosis, estimate suicide risk, and additional consideration when evaluating patients in a specific treatment setting. Assessment of patients with suicidal behavior is a complex evaluation process. It has been a traditional clinical teaching, and all practitioners and mental health professionals have undertaken it. We need to be just recapping the process. The first step involves identifying specific psychiatric signs and symptoms. The second step is to assess past suicidal behavior, including intent of self-injurious act. And the third step is to review the past treatment history and response to treatment. The fourth component is to identify family history of suicide, mental illness, and dysfunction. The fifth is to identify current psychosocial situation and nature of crisis. And the sixth is to appreciate psychological strength and vulnerabilities of the individual patient. The problem of predictability of suicide is epidemiological. Suicide is a low base rate behavior. If you see the United States data, in the community, in the population, suicidal ideation is seen at the rate of 5.6%. But the suicide attempt rate is 0.7%. Further, the rate of completed suicide is 0.0107. It is this rarity of incident in the population statistics that makes the task difficult. For estimation of suicide risk, the common and proven path is to talk about risk factors. There are several risk factors which are known, but the difficulty is the weightage of each individual risk factor is not clearly known. Most reliable risk factors are history of a recent attempt, history of suicide in family, history of depression in family, history of other mental illness in the family. There are several ways to look at these risk factors, and one way is to classify them between predominantly non modifiable or predominantly modifiable risk. The factors which are non modifiable are perhaps beyond the intervention scope. For example, past history, family history, demographics, etc. The focus on identification of modifiable factors should be more emphasized in order to make the intervention more productive. Couple of interesting observations about risk factors are that in any given case there are multiple factors present. Now these factors do not work on isolation or in isolation. They work in two different ways. One, they can be simply additive, or they can work in a synergism. For example, the combined risk associated with comorbid depression and physical illness may be greater than some of the risk associated with each in isolation. So therefore the whole sum of risk because of multiple factor becomes many more times than just simply the sum of these factors. There are certain qualities which are appropriate and reasonable in assessment tool and which are necessary. An important part is developing the instrument which can successfully differentiate between individuals at serious risk and those who are not. That's the whole purpose of having the assessment, to be successfully predicting those who will attempt a suicide and those who will not, and any scale or instrument or rating scale which is developed or used should have this outcome criteria. Desirable qualities of a scale are well defined, and it is expected that the scale which is being used should have a high validity, should be free from cultural influence, should be specific, sensitive, and reliable, should be able to be used by all mental health professionals, have success in predictability, may be applicable across medical settings, may remain free from bias, and have minimum false positive and false negative results, and conceptually should incorporate available research evidence and can function as a guide for treatment and care planning and appropriate clinical decisions. We feel that in our contemporary work, the concept of risk is constantly evolving, and we need to upgrade it in order to bridge the gaps which are existing in clinical practice. In the third module, we will be talking about a review of the concept and how do we measure the risk in a given context. Concept of risk has been questioned since long, but that is another debate which is more philosophical. It appears that it is continuously evolving process. We have more research and more information, our understanding increases, and the concept also becomes different. By and large, suicide is a multidimensional concomitant of psychiatric diagnosis, especially mood disorders, and is complex in both its causation and in the treatment of those at high risk. Risk and protective factors tend to be fairly consistent worldwide, with some cultural variations only. Even with standardized assessment and prediction scales, such as the Hamilton or Beck depression inventories, suicide prediction results in a 30% false positive. The present work conceptualizes understanding of risk in a new direction. We did an electronic search of all possible risk factors which have been reported in literature from biological, social, psychological, environmental, and psychiatric, medical, cultural, spiritual, and familial domains. And we found 76 factors reported as risk factors for suicide. The common risk factors are gender. We know that suicide is 3 times more common in males and attempted suicide is more common in females. Then previous attempt, which is very high risk factor, family history, presence of a mental disorder, substance abuse, life event or loss, and history of trauma or abuse in growing age or childhood. In the present concept, we derive from biopsychosocial model of mental disorders. And we propose that as any psychiatric disorders have 3 different components, biological, psychological, and social, similarly, suicidality spectrum or suicidality domain also has 3 different origin. To have a sketch of conceptual framework, we can imagine that there are 6 concentric circles. The central core represents the biological, genetic, and familial risk. The second circle represents psychological, developmental strength. The third circle represents the strength of social and environmental factors. Then there is a spiritual factor which plays its own part. There are pathological states, mental illness, substance abuse, morbidity, and the last is the protective factor layer. This is one of the conceptualization that how different spectrum, different parameters can combine to give rise to suicidality. What we mean by this is if we have to be strategically intervening in a given case and reach to the core of the biological and genetic and familial aspect of suicide, the attempts have to have multifaceted or multifactorial design which can deal with several causative factors. So we proposed a model wherein we said the risk is measured in relation to strength. That is, it is a ratio of vulnerability and resilience. The second part of our thinking is that risk is also a ratio of risk factors and protective factors. Risk vulnerability spectrum is risk and vulnerability is lying on a spectrum. It is not a dichotomy and there is no definite dividing line. And the concept of risk can well be parallel to stress diathesis model which is popular in psychiatric disorder for etiopathological origins. What it means that the resilience can be converted into vulnerability on a continuum by several stressful factors depending upon the threshold of the disorder. So if we have a high resilience in an individual, that person can also pass through situation and becomes and develop a severe mental disorder or suicidality if the stress factors are extreme. So it's a simple vulnerability hypothesis which we are trying to correlate with suicidality. The third point in this proposition is that current concept of risk is a ratio of risk and protective factors. The protective factors are consisting of spirituality, belief, attitude, support system, personality development, etc. And the risk factors arise from current stressors and poor coping mechanisms, mental disorders, physical illness, or substance abuse problems. The fourth component, we believe that there are two kinds of risk factors. One can be called as trait risk factors, which determines lifetime risk, and it originates from learned coping mechanism, adverse childhood experiences, presence of mental illness, and genetic and familial components. The other group can be called state risk factors, which is variable and determines current or situational responses. And this group of factor arises from personal belief, current mental state, lack of support system, and recent life events or loss that an individual is going through. Now, how do these two group of factors interact and develop a situation which is a high risk situation for suicide attempt? The process of ideation to attempt is highly complex, and very little is known in literature that what are the changes which take place psychologically and biologically to convert a dormant risk into an active risk and convert a person from being not suicidal to suicidal. We conceptualize that these two risk factors are in terms of a mechanical wheel which are interlinked to produce absolute risk. And therefore, the absolute risk is dependent upon both the state risk and trait risk. And therefore, the assessment and intervention both should be directed and designed in these two parameters. Based on this understanding, we classified and regrouped the risk factors into 5 different domains: biological domain, psychological domain, social domain, spiritual domain, and current vulnerability domain. We then designed questions to represent each one of these and developed 8 different categories: biological, clinical rating, demographics, psychological, primacy or recency, family history, axis 4, that is psychosocial, stressful factors, and protective factors. In these 8 different determinants, we classified the questions that we had framed to represent almost entire range of risk factors known. There is strong research evidence that consideration of the most prominent risk and resilience factor, which was identified by 16 experts in the field, they came up with 21 commonly mentioned indicators. We incorporated this body of work to make sure that the list of questions we designed necessarily has these recommended factors represented. Most importantly, to incorporate a dimension of protective factors like self-esteem, stability of home environment, etc. So in the present construction of present scale, we incorporated and taken care that the contemporary research is represented and it remains comprehensive and multidimensional in its origin. We then decided about outcome criteria as to what are we going to test, and how this is going to be put for a field trial. So we developed three different groups of outcome criteria, that is clinical disposition, current resource utilization, and services for aftercare. So that means we assess a patient and we try to check whether the clinical disposition can be guided by the new psychological assessment tool or not. We also see whether the tool can guide how best to utilize the resource, or which kind of resource would be most suitable for a given client, and if possible, uh, whether in long term it can tell us what kind of services for aftercare would be suitable for a given client. We used clinical disposition as follow up and specialized resources, and in the category of current resource utilization, we considered the crisis plan, client's referral to outpatient services, crisis unit follow up, client referred to specialized addiction services, clients who were referred for shelters, clients who were referred for safe bed, and finally, whether they were hospitalized, and if hospitalized, whether they were hospitalized involuntarily or voluntarily. So, therefore, we checked the suicidality level, risk level across the correlation factors for clinical need for the situation. We call this scale as scale for impact of suicidality, management, assessment, and planning of care. Every domain has certain questions from that field. Each question scores 1 for affirmative answer. So in demographics, there are questions about age, gender, marital status, and whether number of children living with them, or the patient is inpatient or outpatient, the basic information. In psychological domain, we have tried to put in questions which test whether the person is what is the understanding about life in general, whether he is in a state that feels life is worth living or it is better off to be dead. Does he have ideas of hurting himself? Is there a factor of ambivalence, or there is a factor of determinants? So the questions are designed in a way to understand most of the known psychological complexities in suicidal ideation. Then there is dimension of current state of suicidality, which checks that do you currently feel suicidal, and has questions for dimension of hopelessness, worthlessness concept. In the psychological domain, there are questions: have you attempted to kill yourself? Did you want to die? Were you certain that you wanted to die? Did you want attention from someone? At the time of your attempt, were you depressed? At the time of your attempt, were you angry to yourself? Do you want to attempt again? And several other questions which are structured around psychopathology of suicidal ideation. Then there is a group which tests for the planning for subsequent attempt, uh, asking and inquiring about: do you think you will get suicidal ideas in future? Will you be able to cope? Do you think you will attempt suicide in future? Do you think you need treatment or help? And next is the dimension of comorbidity, which we all are familiar with its high risk nature. Then there is dimension of family history, presence of suicide attempt in the family or death due to suicide, presence of mental illness, addiction or alcoholism, because there is a strong genetic link between mental disorder, alcoholism, and suicide. The scale then goes into further details about biological domain and presence of mental disorder. Then we have protective factor domain, in which we inquire questions: do you benefit from community or outpatient support or counseling? And we inquire about perception of support available, and the factors which are dissuasive for suicide in his or her own life. what is the worth of self-esteem and a kind of meaning to self, how much it is present or not present. Then there are items for clinical rating. If there is an evidence of personality disorder, impulsivity, is there any personal crisis, dysfunction, or chaotic home situation? The last domain, that is psychosocial factors, we have utilized DSM 4 concept to classify 8 different subgroups, and that is problems of primary support group, problems of related to social environment, educational problems, occupational problems, housing, economics, access to healthcare, interaction with the legal system, and other psychosocial problems. And that completes the scoring, and which takes about 20 minutes and can be done as a standard history taking procedure. While scoring, we take care that the subscore on protective factors is subtracted from the total of all other factors. In a methodology of testing it, we had the draft and the scale. We did a peer review and proceeded for necessary approvals and did a feasibility study and continued and conducted educational workshop and did inter-rater reliability, developed training module and video based case vintage. We ran the pilot field trial and different settings and populations, did the outcome and psychometric analysis, and further further trial across treatment setting is being done. The psychometric properties of SysMap has been quite encouraging. The inter-rater reliability of the scale was assessed by videotapping a case vintage in which a therapist administered the structured interview to mock clients. 20 clinicians of crisis relapse prevention services and admitting unit in the assessment program at the Regional Mental Health St. Thomas participated in the study. They familiarized themselves with the scale and participated in the workshop and did the inter-rater reliability work. It showed a reliability of 0.71 and 0.81, which was statistically highly significant. In the field trial, it has demonstrated a specificity of 78.1% and sensitivity of 66.7% and validity of correctly classifying as 74%, which is quite an encouraging report seeing the contemporary other scales. On comparison with other popular scales, SysMap comes out as parallel to others on all parameters. We compared with the suicide potential scale, SPS clinical scale, Beck depression inventory of suicidality, and we found that in all sensitivity, specificity, and ability to correctly classify, this particular new questionnaire came up with good statistical values. So in results, what we found is that there is a correlation among variables and admission status. Whether individuals were admitted or not was highly correlated with the various outcome measures. The analysis demonstrated that admission status was correlated with subtotal in protective domain, suggesting that individuals with higher level of resilience factors were less likely to be admitted. And this has been a key assumption and foundation of the concept in constructing this particular scale. Additionally, the individual item of previous suicide attempt and the presence of psychosis was correlated with admission status. And it is a relevant clinical situation that patients who have previous suicide are they remain at a high risk, and those who are in incipient psychosis or in frank psychosis tend to get admitted much more. So classifying individuals using the SysMap, the specificity of the scale, that is ability to correctly identify individuals who did not require admission, was 78%. And the sensitivity of the scale, that is, ability to correctly identify individuals who required admission, was 66.7%. A false positive rate of 33% and false negative rate of 21% was also seen, which is not very high but high enough, I would say. So we recap the case that we discussed in the beginning. Now, these are the scores on various subtests of this scale, and this patient scored 37 total score, 7 on protective factor, and total suicidality factor comes as 30, and which is suggestive of consideration for hospitalization. Seeing the cutoff points, it is clear that those who scored 13 to 23, these patients are most likely to be followed up in the outpatient. They are not required to be admitted, and counseling and general measures of help should be sufficient. Those who score 23 to 33, we need to consider possibility of a psychosis and previous suicide attempt, and protective factors as being strong. This is a borderline group which needs closer monitoring. But if an individual scores more than 33, hospitalization is highly recommended. Carrying this work forward, we hope to generate a quotient ratio of risk and protective factor, which can give rise to a visual impression or a graphic representation of absolute risk for risk applicability. The concept and data needs to be validated. The work is carrying on. We hope we can test the scale in several different settings and come up with visual expression of the risk depending upon the concept that we are using. Thus, the recommendation for good clinical practice or clinical governance is continuing medical education for psychiatrists, mental health professionals, family physicians, law enforcement personnel, and correctional officers, etc. Keeping in mind that strategies to improve risk assessment would lead to strategies to improve education, building skills, and learning clinical skills, and they would be consequential to strategies to review efficacy of policies that an institution places. And therefore, the continued education, strategic intervention and assessment, and policy practices are quite interlinked, and they are in form of a chain reaction. So this was about what is the challenge which is present due to suicide assessment piece, how difficult it is, and how we can improvise the situation, what we think should be the concept of risk, and we proposed 4 different aspects of contemporary thought on risk, and developed a scale which has all possible, most of the risk factors within it, and which comes out to be a statistically successful scale to be used, and we are continuing to use it. We hope that this would be helpful for clinical practices to our fellow colleagues. I'm highly grateful to the institution, Regional Mental Health Care, where the work has been carried out, and Dr. Germain, its site chief, and our physician lead, Robbie, and administrator, Catherine Grover, Ruth, the Department of Crisis Services, our programs, a number of people who have participated, supported us, encouraged us, and a number of clinicians who have actively participated and are still continuing with the work from both the unit, the crisis services, as well as assessment unit of regional mental health. I am grateful for their support and encouragement, and I'm thankful to all of them. But for their active participation, the initiative was not possible. And whatever I am presenting is it's our joint effort with Dr. Nelson and myself, and we would like your feedback very much. Thanks.